Hi, I am Dr. Shripad Banavali. I am Professor and Head Department of Medical and Pediatric Oncology at the Tata Memorial Hospital, which is based in Mumbai, India. We have been treating cancer with chemotherapy or what we call systemic agents for a long time now. And the way systemic therapy usually is done in oncology or in cancer treatment is that in the phase 1 studies, we take a drug and then go up and up on the dose of the drug till we start seeing toxicity, and that is called the maximum tolerated dose by the body. And at that dose we start doing clinical trials and give it to the patient and see the efficacy. However, this may not be the best way to treat patients because toxicity does not correlate with the efficacy many times, and that is why actually there is a new way that we have been started to use, especially for patients with advanced cancer. Initially it started with patients with multiply relapsed or recurrent cancers in palliative setting, and that is called metronomic therapies. So what exactly is metronomic therapies? Metronomic, the word comes from a word called metronome, which is an instrument actually which gives beats at a regular interval, and it helps the Western musicians to basically play the instruments in a regular rhythm. So metronome gives a regular beat at a regular interval in a continuous fashion, and same way metronomic therapies are basically therapies where we give a drug at regular intervals in a continuous way, not like in MTD based therapies which is given once every 3 weeks, but it is given more in a continuous fashion, for example once a day, twice a day, once a week. So that type of therapy. Now when you are giving drugs at such a small interval or a continuous basis, you cannot give it in high doses. So we have to decrease the dose of the therapies so that the patient can tolerate it, and that is why actually in metronomic therapies usually we give drugs in a very low dose, many times 1/10, 1/100 the dose of what we normally give in MTD based therapies, but it is given continuously over a period of time, and sometimes we give for even years in certain situations. So this is basically what metronomic therapies is, and actually metronomics is a word which we have derived. Actually initially it was called metronomic therapy, but metronomics is what when we have actually included drugs which are chemotherapy drugs, and along with that we do what we call drug repositioning or repurposing, and when this thing comes together we say the economics of chemotherapy or economics of cancer care, and that's how the term metronomics was coined, so that it gives an idea not only of the therapy that we give, but also it suggests that these are the low cost or basically affordable type of therapies. Now when you do metronomic therapies, there are certain issues related to that. Now if you are giving a drug every day or twice a day, you cannot give it in an injectable form because it will be impractical to do, and patients will not be able to take it, they will stop using it. So most of the metronomic therapies that we give are oral drugs. So these are oral drugs given in low concentration over a period of time. And what we have done actually, so I work at the Tata Memorial Hospital, where 70% or 65% of our patients that we see are from the general category. Basically they are general patients, they cannot afford really the expensive latest therapies, and this when the patients develop recurrences, we were giving this type of therapies in palliative setting. At the same time, Tata Memorial Hospital actually was involved or is now associated with BKL Valavalkar Hospital, which is a rural hospital in interior of Maharashtra in Konkan area, that's nearly 300 kilometers away from Mumbai, and Tata took it up as its rural outreach program nearly 20 years back. And when we started going to this center, now with Tata we are already seeing general patients who cannot afford really expensive treatment, but when we started going to this rural hospital, the things were compounded in the sense that these patients who absolutely cannot afford even $1 worth of treatment, sometimes, or $2 also is a big amount for them, and we had to either not give them the therapy or do something that in which way that we can basically bring down the cost of therapy. But cost was not the only issue. Along with the cost, actually what happens is in many of these patients were in such poor nutritional condition, or nutrition of this patient was so poor that when we started initially giving them the so-called standard of care or standard therapies, many of these patients wouldn't tolerate that, and the side effects were compounded. So we had to not only take care of the financial issues, but also the issues of nutrition, and basically see that we give them therapy in such a way that basically they can not only afford it but also tolerate it. And that is why we started exploring the metronomic therapies here, not only in the palliative setting like we did at Tata, but also in a new setting, basically in patients who are newly diagnosed with cancer. And that's how metronomic therapies, then we shifted gears and started treating even patients with newly diagnosed cancer with these therapies. Another aspect of metronomy of cancer in India actually is that, basically many of the patients with cancer who are diagnosed in India come in an advanced stage. Whereas in USA, if you see, for example, in breast cancer, the average size of a patient with breast cancer, the lump size is less than a centimeter now. Whereas in India, we have average size maybe 4.5 centimeter in cities. In rural areas, it's even more. So patients come with advanced disease. Many of them come even with metastatic or spread disease. Now, when the disease is advanced or spread, what happens is the outcome decreases. That means the cure rate of these cancers go down. So many of the patients, even if you give them so-called standard therapies, many of the time the disease comes back. And in India, actually, we have seen that if the disease comes back, most of our patients will not take the second line of therapy, will not further take therapy, and they will stop treatment. So in India, usually what we call our event-free survival, that means survival without any event, is the same as what we call the overall survival. That means whereas in the West, even if the disease relapses, many of these patients take second line, third line, even seventh line of treatment, and they can go on for years. In India, if it comes back, that means it's gone. So what our aim was is not to only treat this patient, but to make sure that if we treat them, the disease should not come back also. And in this setting, we thought actually metronomic therapies would be an ideal way to not only use it in palliation or the palliative setting where we give such treatment only to decrease the side effect, the symptoms of the patient, or give them symptomatic relief, but we also started making sure that if we give this patient so-called standard therapy, then after that, if we continue them on maintenance with this metronomic therapies, the chance of the disease coming back will be decreased, and we will be ultimately able to improve the survival or the cure rate of this patient. And this is the concept with which we started working on metronomic therapies initially in this rural hospital in Derband, and after we started getting good results there, impressive, promising results, actually we brought this concept to the Tata Memorial Hospital in Mumbai, and here we are now doing, see all the data in the rural hospital was retrospective, it was one-on-one basis, but in Tata Hospital now we are bringing this concept and doing now clinical studies, scientific studies, wherein we are comparing this metronomic therapies with the so-called standard of care and trying to see if this really would help to improve the cure rates or improve the outcomes in the patients with cancer. So that is where we are now at present, and in Tata at present we have nearly 7-8 studies ongoing where we are doing prospectively trials of using metronomic therapies in different settings, and the most important ones where we are using is in the head and neck cancer, because in India actually head and neck cancer is the #1 cancer in most of the centers, including in Tata. Head and neck cancer is the #1 cancer, and since most of these patients come with advanced disease are from the poor socioeconomic strata, we wanted to develop simple basically therapies which will be affordable to this patient, and then basically will also help to improve the outcome of our patients. So this concept is not new, metronomics, everyone feels this is a new concept. Actually it's not. The name given is new. For example, this name was coined around 2000 when basically two different centers, one Dr. Judah Folkman from Harvard in Boston in USA, and Dr. Robert Kerbel from University of Toronto in Canada, they did a similar work of anti-angiogenesis. That means blood supply, how the blood supply or affecting the blood supply helps to take care of the tumor, and this both things came together at the same time. And when these were published at the same time in two different journals, there was a third journal and a third editorial written on this subject by Professor Hanahan, who is one of the big names in cancer, and he coined this word metronomic at that time to give this name to this thing. But actually we, even at Tata Hospital, we have papers where we have presented the same concept, the same work, but at that time in 1997 we used to call it biological response modifier based therapy or BRM therapy, and we were using the same concept. So the concept is not new, the term is new, and the most important, actually the most common example of metronomic therapies is in the treatment of childhood acute lymphoblastic leukemia, which is a type of blood cancer, in the commonest cancer in children. And actually this is one of the most successful model for treatment of any cancer, actually, for that matter. And up to 30-40 years back, the cure rate of ALL or childhood ALL was 0. That means none of the children survived. From 0, now we have gone up to more than 94% overall survival in children with acute lymphoblastic leukemia. And the treatment of this leukemia was based on metronomic therapies, though we didn't know the term. But the induction therapy, in the induction of this treatment, we give various drugs either daily or alternate day and weekly. So this is the concept of metronomic, and after that we actually at the end of treatment we give the children maintenance therapy, that means oral drugs for 2 years. So this is exactly the principle of metronomic therapies, and it was done, like I told you, even 40 years back. So this concept is not new, but the term is new. It's around 15 years. But more importantly, actually the science behind, the biology behind metronomic therapies is being done for the last 15-16 years now. Many of the biological studies are being done in the Western countries, especially there's a lot of body of work from Italy, USA and Canada, and to some extent in Israel. So these are the 4 major hubs of metronomic therapies world over, and France actually, so that's another one. So these 4-5 countries are doing maximum of the biological work or the laboratory work in this, but more importantly, lot of clinical work has been done in India or is being done in India. And actually there are only 2 countries where really this work is going on in a big way. One is Italy, where they have done a lot of metronomic work, especially in breast cancer. And in India we have done a lot of work in different cancers, but more importantly in breast cancer we are doing work, in head and neck cancer we have done a lot of work, and in certain rare tumors. So these are the major places doing work on metronomic therapies. And in India, I think we are one of the biggest country maybe where we are doing a lot of clinical work. But at present this is still a young science, and unlike in trials which are what you call drug discovery trials, that means any new drug which is discovered, you have to do various phase 1, phase 2, phase 3 trials, and basically ultimately you have to do the phase 3, wherein you compare the standard of care with the new drug and show that it is better than this thing. That's called a phase 3 trial, and that's the level 1 evidence. So by doing that, if we show this is good, then that becomes standard of care. But that requires billions of dollars to do research, to do these studies, especially when you have thousands of patients involved. So this takes a lot of money, which can be done by drug companies. However, since these are drugs which are time tested, which are generic, which are off patent, there is no company to support metronomic therapies, and that is why we need to create the awareness. We need to create, ask the government or these NGOs like Wellcome Trust or Tata Trust, who can help us do these studies, because you require money to do any studies and will not get it from the drug companies. So I think we should create this awareness, because I feel basically this, we talk about made in India for other things. I think these metronomic therapies would be a prime example of what we can do in India for the patient with cancer, because not only it will help taking care of patient with cancer in India, but there are so many other low and middle income countries wherein there are thousands of patients with cancer, and it has been projected that by 2050, 70% of the world's cancer patients would be in the low and middle income countries. Sometime back we always thought that basically cancer is a disease of developed countries, of lifestyle related conditions, and most of these patients are in the developed countries, but it's no longer so. 70% of the world population of cancer would be in the low and middle income countries, and unless we do something for it now, I think in this condition it will be out of hand, and most of our patients will not be able to afford the type of therapies which are being propagated, which are being conducted at present. And we have to change this and make sure that we develop not only effective therapies but also affordable therapies for patients with cancer. And I think metronomics is one area which I again, like I called it, the economics of cancer treatment. and these therapies, low cost but effective therapies, will be the need of the hour for if we have to tackle the problem of the cancer epidemic, which we are about to see in this thing. And it's not because I don't want to frighten people. It's not that the cancer rate is going to increase, but the very fact that our population is increasing, most of our patients are living long, and as you know, cancer is a disease of older people. So at independence, at the time of independence, our average age of an Indian was in the range of 47 years. From 47 it is gone up to 67, 69 years at present. So as we grow older and older, there is a high chance of developing cancer. So just because of that, we will see more number of cancer patients. Because our population is in billions, sheer number of patients will be more in India. So all this together, and even the lifestyle is changing. So many a cancer, type of cancers like tobacco chewing, alcohol, obesity, all these are basically lifestyle related cancers, and these are increasing. So overall we are going to see more number of cancer patients, and we have to wake up now and make sure that cancer is treated in an affordable manner. Because I always say, it's the most important challenge in oncology is not just to find cures, but to find affordable treatment. Because we have seen many patients which actually basically die not only of cancer, but along with cancer, basically the patients also, the whole family is ruined. And if you don't have affordable treatment, I think we will not be able to prevent this. Yeah, the most important reason is basically, in India and in all other developing countries, how we treat patients is done by guidelines. And most common accepted guideline is the NCCN guideline, which comes from the USA, or the ESMO guideline, which come from Europe. And there they are, concentrating more and more on drug discoveries and not on drug repurposing, like I have been telling what we do in metronomics. So I think we have to create the awareness. We are taught what comes from the West is the right way to treat, but that may not always be the right way to treat in our circumstances. And I think we have to develop our own data, our own basically studies, and that is why we have to create the awareness of metronomic therapies, try to get funds, try to come together. We have a national cancer grid developed at the Tata Memorial Hospital, wherein we have 74 centers working with it. So through this national cancer grid, through creating awareness, I think we should do more and more scientific studies, because at present we have level 1 evidence. We need, level 3 evidence. If we need level 1 evidence, we have to create randomized trials, and that is where we are lacking. So that acceptance is not there, unlike what is done in the West. I think most importantly, I think if we have to make it popular, we have to do more and more scientific studies, laboratory studies, biological studies, and show that it works. So I think once we start doing that, it will be more accepted. Already we are getting more and more acceptance, but to get it acceptance at the scientific level, we have to create level 1 evidence, and that is where we are lacking at present. And once we do that, I think it will be more acceptable to the oncology community. I think we have plenty of students at Tata, and I always tell them that if that's the basically metronomics is the future of oncology, especially because up till now we were targeting more on the concentrating more only on the cancer cell, that is we were targeting the cancer cell alone. But as we understand now, cancer is not only the cancer cell, but the cell along with the environment that this cancer cells are, and along with that it's the body's immunity that together forms the cancer. And unless we tackle not only the cancer cell, but change the microenvironment of the tumor and modulate the body's immunity, we will not be able to cure cancer. And that is why at present we are lacking, especially patients with advanced cancer. We are not being able to cure, especially in adults. Childhood cancer is a different story, but in adult oncology, patients with advanced cancer, today we are not able to cure most of the patients, and that is because we are targeting more and more just on the cancer cell. We have to change this, and that is the reason, one of the most fundamental difference between the standard MTD based therapy and oncology and metronomic therapy is that in MTD based therapy, again we just look at the basically killing the cancer cell. But when we kill cancer cell, there are many other changes which are harmful to the body also can occur. So what we have to do is combine this MTD based therapy along with metronomic therapy, and when you do together, not only target the tumor but all the environment and the immunity, I think that time we will be able to cure more cancers, and that is the future of the therapy. And that is why I always tell that metronomics is the next generation targeted therapy, and that is the future of oncology actually, as per whatever I have seen in this thing. But we need, again, like I told you, just talking is not enough. We will have to do these studies and prove that it is useful. That is what we are concentrating on now.